Significance of Multidisciplinary Approach in Glycemic Surveillance by Dr. Hafeeza. Over to you, Dr. Hafeeza.
Assalamu alaikum, everyone. So today I'm going to talk about the glycemic surveillance, significance of glycemic surveillance in diabetes. So as we all know that diabetes is on the rise worldwide, with a global prevalence in adults being 8.8% of the world population, which reflects uh, a population of 425 million adults globally with diabetes, with an estimate of 48% increase to around 628 million people by 2045. So the cost of care of these people with diabetes now account for 727 billion US dollars uh, globally, and it will keep growing. But one of the most alarming thing about this is in these figures is according to the IDF that as many as 212 million people who are living with diabetes are not diagnosed or undiagnosed. That is around 50% of the diabetes are undiagnosed. And according to the 2017 facts numbers, uh, in 1 year, in 2017, 4 million people died from diabetes, which ranks it about the seventh leading cause of death around the world. So globally, as we are talking about the diabetes in pregnancy, so globally, 20 million live births, they are affected by hyperglycemia during pregnancy worldwide. Uh, Again, the figures are from the IDF 2019. That makes it 1 in every 6 pregnancies. So let's have a look at the figures in Pakistan. According to the IDF, Pakistan is the fourth highest number, as at the fourth highest number of patients with diabetes, which makes it around the population of 19 million diabetics in Pakistan, and with a prevalence of 17.1%. And every year, 190,000 cases with GDM are diagnosed. Let's look at the local numbers. As Professor Shabin has rightfully pointed out that the local numbers are erroneous. What we see is in Pakistan, the disease was mostly unnoticed with no significant data available to date about the prevalence of disease and development of preventive strategies. So there are some conflicting results are available within Pakistan showing a varied prevalence ranging from as high as 26% in Peshawar and 4.2% in 4.2% to 8% in Karachi in different studies, and around less than 1% in Lahore, 22% in Balochistan. So it is difficult to project the true numbers since these studies recruited limited number of subjects and implied different diagnostic criteria for identification of GDM, adiposity, sedentary lifestyle, advanced income. These all are the factors which are leading to increased number of gestational diabetes in Pakistan. So we need to have more data to reflect the true numbers in Pakistan. So let me bring you to uh, physiology of the normal physiology in pregnancy. So you know that one of the common physiological change that occurs during pregnancy is the development of glucose intolerance, which causes a hyperglycemia. This is referred to as well, this is a normal physiological change. That normal pregnancy is a state of insulin resistance. So these changes do not reflect a pathological condition, rather than they represent a necessary, indispensable adaptation to meet the energy demands of the fetus to prepare the maternal organism for delivery and lactation. Also, the growing fetus needs the uninterrupted glucose supply for its growth. So this transfer of glucose from mother to fetus is not only it's not insulin dependent. It's mostly through a gradient which is created by low fetus blood sugars, which is less than 20% of the maternal blood sugars, and so compensate or provide for the fetus the maternal hyperglycemia occurs. In addition to all this, early in pregnancy, the maternal estrogen and progesterone, they increase and promote the pancreatic beta cell hyperplasia and increases the insulin release around 30%. So if you see here that earlier in the conception, the insulin requirements in the diagnosed type 1 or type 1 diabetics, they decline. And when around 16 to 20 weeks, it increases rapidly, about 5% per week, to up till the last of the at 36 to 40 weeks, in which in that time, which is the highest insulin requirement for the patient. So this change of the insulin levels is due to the placental hormones, the HPL, the cortisol, the prolactin, progesterone, estrogen. This leads to the insulin resistance in peripheral tissue. So pregnancy is an increase is a state of increased insulin requirement. So because this hormones confers the increased tissue insulin resistance as their level rises, the demand for increased insulin secretion with feeding increases progressively during pregnancy. So as the pregnancy progresses, the placenta they continue to develop and more hormones are produced. So it further increases the insulin resistance. It's also a sign of healthy placenta. If the insulin, if I tell you that if the patient's insulin requirement is dropping suddenly, it also suggests that placental insufficiency is present. So it accounts for the small for gestational age fetus. It results in placental abrasion or fetal death. So the insulin levels are lowest in the first trimester and highest in the third trimester. So if it is normal, why do the GDM occurs? So if you look at this, like the placenta hormones, which leads to increased insulin resistance, there is compensatory increase in insulin secretion from the mother. So which keeps the blood sugars in the mothers in the normal ranges. If that doesn't occur, if the mother is unable to produce a sufficient insulin to counter insulin resistance, then the hyperglycemia occurs and the GDM occurs. So that is what is going on around the about the pathophysiology and physiology of the normal and the GDM pregnancy. So we'll discuss about the how would we monitor the blood sugars in a diagnosed case, what is the importance, what are the targets, and what are the tools for measuring the blood glucose in the pregnancy. So we usually use SMBG with HbA1c for monitoring and for the holistic management of diabetes, because they both augment each other and help us have more accurate results in terms of target achievement. So what are the glycemic targets in pregnancy according to the ADA? The fasting and postprandial SMBGs are required, and the fasting, as told by Professor Saiba, that the glucose in the fasting target should be less than 95, and 1 hour postprandial less than 140, 2 hour postprandial less than 120. And HbA1c throughout has to be less than 6% for a normal pregnancy to occur, for less association of the gestational diabetes complications. Why is it low? Because as you know that there's a physiological increase in red blood cell turnover. So HbA1c is lower in the normal pregnancy than in the normal non-pregnant women. So that's why the HbA1c targets are redefined, are there. They are created to be lower in pregnancy than the non-pregnant state. But these targets have to be achieved without any hypoglycemia. So if you look at the three main school of thoughts, they are usually on. They are more or less on the same page. The ADA, the Endocrine Society, and the Society of Clinical Endocrinologists, they the three of them recommend almost the same thing. Almost the only difference is the clinical endocrinologists aim for a slightly lower HbA1c and blood sugar levels as compared to the endocrine society. So for more or less, the targets are the same. So one of the tools we use for the management is for monitoring of the blood sugar is SMBG, self-monitor blood glucose level. What is a structured SMBG? Let's discuss that. So there's a pattern in which is different in each patient. There are three types of events which occur in a diabetic pregnancy. Either they can be hypoglycemia, they can be hyperglycemia, and there can be a normal normal blood sugar. So for each patient, the pattern differs. So this glucose pattern management is a process of recognizing the glucose patterns, analyzing what is causing out of target readings, and then taking steps to bring reading back into the target range. So it is also sometimes referred to as a pattern control or glucose pattern control. And this process basically provides patient with information to make decisions regarding their diabetes self-management, and also enables the healthcare provider to understand how their day-to-day choices are affecting their glucose levels, and and to make the decision which is customized to their needs. So that's how the structure is being made for us SMBG. So structure testing means that the testing has to be at the right frequency, at the right time, and in the right situation according to the information. Uh, and these information are needed for better treatment decisions. So structure testing requires that the patient and the physician agree on the goals of the glycemic control, which we discussed are the targets in gestation, and we should patients should be agree why they need to test, why they need to test so much, and when they need to test either preprandial or postprandially, or how frequent they need it, and what are the target values for each of the levels for it to be in the normal range. So, and they also have to know that how to record and share their results. So this all the components make it is a structured SMBG, which your patient should be knowing about. So when you structurally test this, when the patient comes with this structured testing, the pattern analysis is easy. Decision making is according to the testing, and the appropriate action will be taken by the physician. So why is it why the monitoring is necessary? It encourages the patient self-management, behavior change regarding to the lifestyle choices. When he or she will know that what is what went wrong with eating a high carb meal, he will automatically adjust when he'll see the results that blood sugars are on the rise by frequent checking. He will be she will be more compliant uh, to the plan you have given them. So it is very necessary for informed therapy adjustments, for potentially reduce the glucose variability, and utilize it for it can guide the patient and as well as the physician to process MBG to make it simple and efficient, and enable better outcome for the diabetes management. So, what is the accuracy of the SMBG? Why the accuracy is important? Accuracy is dependent on the instrument and the user. So, it is important to evaluate each patient monitoring technique both initially and at regular intervals. Optimal use of SMBG requires proper review and interpretation of data by the healthcare provider to ensure the data is used in timely and effective manner. So it affects the therapy decisions and patient well-being. So if the accuracy will be poor, so there will be poor recognition of the symptoms of hypoglycemia, poor recognition of there will be increased glucose variability, increased HbA1c. So what do you mean by accuracy? Accuracy means that the measured blood glucose and the true value of blood glucose, they have to be on the same page or being close to each other. There are basically two signing authorities for this. One is the FDA and the other is the ISO. So FDA defines the accuracy to be the blood glucose meter provide 95% of blood glucose measurement within the 15% of a credible laboratory readings. So with an inaccurate meter, a patient can have a true value of 400, but the meter will show maybe 300 or 550. Patient will use, and the decision making will be incorrect. Patient will use medicines incorrectly, will not recognize hypo or hyper. So more difficult for us to achieve the targets. This is the Parker's error grid. It was published in 2000 based on a survey of 100 physician attendees at the June 1994 ABA meeting. This meter has been intended for use in assessing the clinical accuracy of blood glucose measurement for patient measurement, self glucose monitoring. So clinical accuracy is focusing on the clinical relevance of the meter results in comparison with the analytical accuracy, gives detailed information about the agreement of the home blood glucose meters in comparison with the reference method. So these were the zones developed, and zone A shows that the accuracy is fine, while the red is that you are in deep waters. So here I would like to, give a credit to EchoCheck meters. They fulfill the requirement of analytic accuracy and clinical accuracy. They are ISO certified, which I mentioned as one of the regulatory bodies, which ensures that the patient is using um, uh, uh, approved meter for accurate blood sugar testing. So another tool we use in the diabetes monitoring is HbA1c. So HbA1c is has its flaws, but it's for monitoring is one of the important tool to look at, because um, it gives the average of the last 3 month blood sugars. What is the HbA1c? Basically average glucose in the blood over the 3 months. As the sugars in the bloodstream, you all know that is attached to the hemoglobin in the red blood cells. Once the sugar is attached, it stays there for the lifespan of RBC, which is 120 days, and it stays. So this is the reason that has to be repeated after every 3 months. But in pregnancy, as I've told you before, that the glycated HbA1c turnover is increased. So the blood sugar has to be the HbA1c has to be frequently monitored in HbA1c in pregnancy. Around ADA recommended it to be monthly rather than 3 monthly. So again, there's a guidance. This is the guidance study, which was a cross-section study including the retrospective data extraction from the medical records of people with type 2 diabetes. So they use a shared protocol from primary specialist care sites in the following in the eight European countries, including Germany, Italy, Belgium, and UK. So the data set for analysis comprises 7,597 cases, proportion meeting process, and outcome criteria determined. So the target
Thank
achievement.
you very much, Dr. Hafeeza. I'm sorry to bother, but would you like to conclude in next few slides because I think we are above the time slot meant for
Okay,
your presentation. I'm
yeah,
sorry.
I'll take 5 more minutes. Yeah. So this shows that HbA1c is target achievement for was lower uh, than the individual. So I'll skip most of the results. So as you know that HbA1c has limitations, so we have to use a tool which needs to be more accurate in terms so that uh, and do not detect the hemoglobinopathies or the HB related problems so that the accuracy of the HbA1c is not compromised. Ji ma'am. So I will like to talk about the integrated personalized diabetes management, which is very important in this new era of online patient seeing and data sharing. So it is basically structures the treatment process, which connects the healthcare providers and patients, and basically it gives you a digital tool that visualize and analyze data. What it does is it improves the patient compliance. Also, it has resulted in um, it has resulted uh, in patient in achievement of the target goals and more accurately and more effectively than as compared to the normal routine procedures. So you all know that for the chronic disease management there exists a clinical inertia of not taking the right steps at the right time. So it basically patients IPDM helps you to overcome this clinical inertia of taking the decisions at the right time initially when the problem is existing. So what it does is, let's shorten this up and let's come on to the IPDM elaboration. So it's a 6-step process which supports the healthcare physician and patient in their joint decision making process. Because you know that chronic disease is or a disease in which in the patient has to live with it, and has the care model is different. In acute diseases where patient comes to you with fever or sore throat or anything else or UTI, you what you do is you give a medicine for 5 days and patient gets well. When the patient comes with diseases like diabetes, when they have to live more than they have to change their life according to that, physician is not on the driving seat anymore. So what they have to do is empower the patient, educate the patient for better decision making, and that makes what makes the compliance of the patient better and targets are achieved in more effective way. So it's a 6-step process. Does is a concept of that structures the treatment process, facilitates communication between the healthcare provider and the patient. So it's a digital tool. Step one is the structured assessment and training of the patient. Step two is the structured therapy adapted SMBG. Step three is structured documentation of that SMBG. And step four is systemic analysis of that data which is gathered around. And step five is the personalized treatment which is given according to that data analysis. And step six is the treatment effectiveness assessment, that you take feedback from the patients that what the problem occurred and where we need to improve. So this is more early recommendation for therapy adjustments. So it leads to the physician-patient dialogue, effective physician and patient satisfaction, and more adherence to the treatment plan and glycemic control. So in this era of the new technology, so it is more easy when you see the patients, when you see your blood sugar control levels or blood sugar monitoring levels at one sheet at one glance, which is possible by this application, which is given to us by mostly basically they are developed by the patients, and is basically a smart diabetes tool.
Thank you very much, Dr.
So
Hafeeza,
it appears
for
like
this comprehensive talk.